All right, all right, all right. We are at another Thursday, so you know what that means. Let's see, we've got 5, 6, 7, 8, 9 studies to get through today. Um, these are actually straightforward. This is nice. I don't have to talk too much except for, I think, 2 of them in the middle here. So first up, association between metabolism and low back pain, a cross-sectional study. It is exactly as the title says. What does your metabolism have to do with low back pain? So if we jump to the conclusion to give us the idea, we have identified significant positive correlation between metabolic health and low back pain. These findings underscore the importance of maintaining healthy metabolic status, providing valuable insights for further research. So we've had boatloads of studies before. This is just, again, adding more fuel to that same message that I've been saying, that if we are to look at a patient in front of us who has low back pain, we have to take a lot of factors into consideration to actually get them 100% better, or as good as I can possibly get them from my clinic. So not every case is going to be purely mechanical. Not every case is going to be purely chemical. There's going to be a sliding scale of how much one factor is influencing their pain versus another. So some people are lucky. Maybe it is just a little bit of something that we have to passively do for them that gets them over the hump, down to almost zero pain and back to their life. That is not a majority of the case, though. Oftentimes, we have to include movements, we have to talk about diet, we have to talk about sleep, because all of these other factors play into you having or being at risk for or maintaining low back pain. All right. So, metabolic factors that they looked at: insulin resistance, body roundness index, again, things that we use in other studies to measure general ideas of metabolic health. So just another one adding fuel to that same conversation. This one I have just a little bit of a discussion for, and it's not necessarily for their own conclusions, it's the inference from the study that we can take forward. So what is this study actually saying? Can pre-treatment verbal suggestions influence the short-term effects of spinal manipulations in young adults with chronic nonspecific low back pain? A randomized controlled trial. So what on earth does that mean? It basically means that pre-treatment, the researcher was cued to say something either positive about manipulation and how it's going to affect the uh, researchee's back pain, really kind of say something passive and neutral, like not positive or negative, and somebody was supposed to say something negative about spinal manipulative therapy in regards to what it's going to do for the patient. And they wanted to see what influence did the verbal cue have when it came to the results of the research. And you can take a solid guess as to what happened. The power of suggestion is, well, powerful. And so if we set up these different parameters, like if you nudge somebody like, hey, this is going to work, it had a better chance of actually working versus, hey, you know what, this is only good for short term and I don't think this is going to work at all. You know what's going to happen? They're not as likely to get benefit. So I'll read through the highlights and I'll kind of go into the pitch that I wanted to get into with this one. Positive suggestions improve short-term clinical effects. Negative suggestions reduced benefits. Verbal framing may influence pain intensity, stress, and pressure sensitivity, and clinicians should consider wording to optimize therapeutic outcome. So does that mean that what we do is entirely placebo? No, not at all. That's not what the study is saying. Um, is this study then confirming like it's purely mechanical then? No, that's actually the opposite. So why do I have this up? Why is this important? um I think this is a broader, if we take a look at this from a broader lens on the power not just of suggestion but the power of expectations, then we can take a look at it from probably a more helpful lens. So if suggestion is so powerful, does what we do matter if all it is a matter of suggestion? What we do absolutely does matter. There are other factors, internal and external, that modify each treatment we pick for a patient that may have compounding benefits in addition to the power of this influence. Put another way, Yes, even if the power of influence is strong, selecting the appropriate treatment modality for the patient, the condition, and everything else that is going on in their life is still of prime importance. Because even if I am very charismatic and I want to dry needle this person and they have a phobia of needles, we're butting heads on the therapeutic benefit of what that needling is actually going to do. Versus if I can pick a treatment that is proven to not cause harm or exacerbate the person in front of me, and even has the chance for therapeutic benefit because it also aligns with patient expectations, I'm leaning towards that treatment, even if it's not the absolute best or most optimized treatment for the patient's condition. That one in particular is quote unquote optimized for that patient based on those expectations. So it really plays into the a model of pain that we can talk about and the balance that we have, and frankly, some of the arguments we have on social media, because we have arguments on optimization, we have arguments on what is the mechanism behind it. Is manual therapy absolute hogwash? Is manual therapy the be all end all? Et cetera, et cetera, et cetera. And frankly, if I wanted to turn this into a 6-hour video, I would dive deep into that. I'll leave it light on the conversation about manual therapy versus not, but I want to dive into setting patient expectations. So first, going lightly into that conversation, I think like everything else on social media, the actual answer probably lies somewhere in the middle of the two extreme camps that you're going to run into. And while I do think that in many cases, manual therapy can be overhyped and overpromised because there are conscious and subconscious incentives on a practitioner standpoint to overutilize manual therapy, I also think it is getting overly demonized in the sense that it is not useless. For the right patient, for the right case at the right time, it is a beautiful thing, a wonderful thing to get somebody over the hump, to reduce their pain, to improve their mobility, and get them to do what is actually going to be meaningful in the long run, which is some form of movement or lifestyle change that got them into that position in the first place. So is manual therapy useless? Absolutely not. And I will die on that hill that it is not useless. So having said that, it also opens up doors for, well, if it's just the power of suggestion, then why bother with manual therapy and learn so many different actual procedures for your patient? You could just pick one, be a master of one, and then just be really charismatic at presenting it. And you know what? There are clinics that absolutely do that. In fact, very lucrative ones. I don't need to be a lucrative one-trick pony doing only one thing and selling it very well. I would rather we have clinicians have a multivariate approach to the patient in front of them with a bunch of different possible techniques that even if they have overlapping effects and they're similar in their potential outcomes, being able to select one that is effective for the patient in front of you because of the other factors involved with that patient, whether it's their perceptions, their expectations, their fears, their body type, morphology, etc. I think that is a fantastic thing that we underestimate the value of clinical flexibility. Being able to be clinically flexible with the patient in front of you, selecting the right treatment for them to get them through that, barrier is to me, in my opinion, fantastic medicine of any kind, allopathic, conservative, etc. So for me, in my office, going back to that dry needling analogy, is it a great intervention for the right person? Oh, yes. But again, for the right person. How many people on here listening to me have a phobia of needles? That unless I am really certain that it is top tier great for them, I'm not going to spend the time trying to convince them to get a treatment they're not going to be happy about, because this study suggests that suggestion has a huge influence into how patients will receive care. Now, if I pause on the manual therapy aspect of this, if we take a look at suggestions and expectations overall, being able to have complicated conversations made simple for the patient to attach meaning to is going to be a key factor determining how successful somebody is in managing acute and chronic conditions. Put simply, if we're able to present this info and set a reasonable expectation for the patient, the likelihood that they're going to get that much better under care is multiplied. It is that much better. So it really ties into providers need to take the time to be able to set these suggestions, do them appropriately, and match that communication to the patient in front of them so that they can tie meaning to what is happening so they're more likely to get results. Because what we don't want is you don't want somebody getting the right treatment with the wrong prep and wrong setup, do it for a handful of days, maybe a couple weeks, traditionally not long enough for almost any intervention, not see the benefits of it, not get better, blame the intervention saying it didn't work, and then go on to suffer continued chronic pain. That is not something we want. So we need to take the time to set up expectations with any intervention, whether it's educational, manual therapy, passive therapy, active therapy, exercise, etc., so that we can truly set the patient up for success, both from an understanding standpoint, from a suggestion standpoint, and a prognostic standpoint. So that was one of the longer studies that I wanted to rant on. Let's move on to the next one before I get caught up in talking about it more and turning this into a 6-hour affair. So, next study, association between systemic symptoms and recovery in acute low back pain, a retrospective cross-sectional study. This basically looked at an in-hospital system of what symptoms patients had coming in with acute low back pain and trying to correlate them to their outcomes post-intervention, post-hospital care stay, maybe prescription, etc. So what did they find? Almost 200 patients with acute low back pain were included in an analysis. Among systemic symptoms, dyspepsia was significantly associated with higher pain at discharge and smaller pain changes. Sleep disturbance and constipation showed associations, but they weren't high enough to really pay that much attention to. But they also took a look at the lifestyle questionnaires that patients filled out, and alcohol consumption was significantly associated with lower back pain at discharge and greater relative pain change, while full hospitalization and symptom duration exhibited nonlinear relationships. So why is that important? What can we do about it? It's really a conversation of the more that your body has to organize, fight through, manage, etc., the more likely it's going to take longer to figure things out. So if we have somebody who is not taking care of their health, who is at risk for things such as the metabolic conditions that were highlighted in study 1, such as dyspepsia, such as alcohol consumption, overconsumption of highly processed foods, not moving, not exercising, poor sleep, you are not having a ton of resources at hand to manage the conditions that your body is going through. So it is more likely to keep the pain signal turned on and turned on high because it's going into a constant environment that it perceives as threatening. So if you don't have the resources or lifestyles to manage what is going on, your body will always presume it's in a threatened state. And one way it can feel protected and avoid things that it thinks will hurt it is by turning on pain. Pain is not bad. Pain is not an enemy. It is just something to understand. And one of the things that your body utilizes pain for is behavior change. If, for example, who here touched the stove when you were a kid? What happened? You reflexively pulled your hand away really, really fast. It hurt a lot. And did we do it again? No. Were we scared of the stove for a little while? Yes. What is your body trying to do? Avoid damage, avoid harm. That's a very visceral and core memory for a lot of kids. What about other places or times that you got hurt? There are checks and balances that your body puts in place to make sure that you don't do that quote unquote dumb thing again. Now, it's difficult because life itself can be complicated when we're looking at these things, but your body, consciously and subconsciously, is going through that triage system of how safe, how protected, and how healthy it is overall. If you are not maintaining your health, it's going to presume that you're not capable of handling these day-to-day stresses. So it's going to what? Turn on the pain, keep the pain on, not let you get out of pain because it is threatened. So the more things that are being thrown at it at any given point, the more likelihood pain is going to be turned on high. that it's going to stay. And that's what this study was saying. Systemic symptoms, especially dyspepsia, may serve as a prognostic factor impeding recovery from acute low back pain. Again, put another way, we have to sort you out as a whole person to make sure we have the best chance of getting that pain signal to throttle down. All right. Next up, comparison of a bunch of different techniques in the treatment of lumbar spine pain. I brought this on here just like the first one because it highlights, let me go down here, where is it? The findings suggest that no single method is universally superior in managing low back pain. Instead, optimal outcomes are achieved through individualized treatment plans that integrate multiple techniques based on clinical presentation, pain chronicity, and functional limitations. Multimodal strategies that combine manual therapy with exercise and patient education appear to be the most effective in managing low back pain and preventing reoccurrence. De facto, basically exactly what we do in the office. So one, I like it because it toots my own horn, shows that what we're doing again is backed by the evidence. Two, it's adding layers and fuel to the conversation. That same thing that I've been harping at this whole time. Unilateral mono therapy clinics are not the best for patients. I'm not bashing monotherapy clinics because there are a lot of them that know what they do and do it very well, but then coordinate and collaborate with other professionals to give the patient the actual full breadth of care that they need to resolve their condition. So again, I don't want to bash single method providers so long as they're following the evidence, referring and collabing with other providers to give the patient the best chance of a good outcome rather than trying to hoard them in their clinic and their clinic only so that they can line their pocketbook. You need clinics that either talk with other clinics, work with other clinics, or clinics that have a lot of options like ours to do most of this in-house. Now, does that mean that I don't collab with other people? Absolutely not. We have nurse practitioners we work with, physical therapists we work with, other hospitals, radiology centers. We understand where we're at and how we can most effectively take care of the conditions that walk through our door. You need to make sure that you find a provider that does likewise. Next up, longitudinal associations between baseline sarcopenia, pathologic muscle wasting essentially, and knee osteoarthritis progression and risk of knee replacement. You can kind of guess it. If you are having less muscle mass, less muscle tissue, and paradoxically a little bit of excess bone mineral deposition, you are at a higher risk of knee osteoarthritis and subsequent knee replacement. So, results. Over 4,000 participants were included. 30% basically were screened to have sarcopenia. They basically had these different algorithms here. So if you see this SCREE-S and PROB-S, that's going to be the different screening questionnaires that they used. So the sarcopenia was screened using the algorithm of SARC-F. They also had the questionnaire screened sarcopenia, so that's that SCREE-S right down here. And then probable sarcopenia from a 5-time chair to stand test. It's a frailty test. So again, if we go back to this, 4,000 participants, almost 30% were positive in the questionnaire, the SCREE-S, and 17% were the chair sit to stand. Baseline SCREE and PROB-S were positively associated with both radiographic and symptomatic progression in knee osteoarthritis over 24 and 48 months. This is the biggest one because I've seen radiographs that are more arthritic than others, but they don't have the associated symptoms with it. Put another way, if you have, 10 70-year-olds that you screen and take a look at their knees just via an x-ray, you could say that, oh yeah, these 3 out of the 10 have way worse arthritis than the others. That does not guarantee that they actually are feeling as much knee pain as the others. So what I like about this is that it's not just radiographic, it's also symptomatic. So the baseline SCREE-S and PROB-S were positively associated with both the radiographic and the symptomatic progression in knee osteoarthritis over 1 and 2 years. Both of those questionnaires and sit-to-stand tests were associated with a higher risk of subsequent knee replacement. Okay. You need to take care of yourself as much as possible. Sarcopenia is something that is on the rise. It is something that needs to be handled and handled fast. At any age, this does not This is not something that if you didn't start doing something in your 20s and 30s, you cannot affect. You can affect it at any age whatsoever. If you're 20, if you're 60, if you're 80. Sorry about that, folks. I just had a little headphone issue. Back to what I was saying. Oh yeah, you can affect it at any age. So you need to move as much as tolerable. I know things can get uncomfortable. I know things aren't always fun, but sometimes it's not a matter of fun. Sometimes it's a matter of priority. So if we're having somebody that has knee osteoarthritis and they're starting to let themselves weaken, but they're also concerned about what they're feeling in the knee, there are lots of programs online and in person that you can seek out to start building up and making a healthy, robust knee, or as healthy and robust of a knee as you possibly can, and reduce your risk of knee replacement, or heaven forbid, you still have to go through knee replacement. You're putting in all that time. It can be thought of as prehab. Your results post-operatively, if you still have to go through the procedure, are going to be that much better if you put the effort in beforehand. So I see this as another call to action that it trends with the other studies that I see, that if you let muscle wasting kick in, if you let sedentary lifestyle behaviors kick in, and again, this is from other studies, you are not treating yourself well for having a wonderful late stage life experience. So no matter how old you are, no matter what you're going through, there are resources available to help manage the symptoms, the disability, the pain, etc., that you're dealing with arthritis. And you really should take 100%, what's the word I'm thinking of? Advantage of the resources available to make sure that you're going to have the absolute best late life experience you possibly can. All right. Last four studies, we're going to go a little bit quicker. The timing of discectomy as a predictor of outcomes in patients with lumbar disc herniations, a cohort study. I'll skip to the results conclusion in my 2 cents. In total, over 1,000 patients with lumbar disc herniations were enrolled. We observed that patients with lumbar disc herniation who underwent surgical intervention within 1 month after the onset of symptoms achieved more favorable outcomes compared with patients with longer duration of symptoms. Residual and motor and sensory deficits 2 years post-op were least common in patients with lumbar disc herniation-associated neurological symptoms lasting up to 1 month. In their conclusion, it supports the importance of timing surgery on the postoperative outcomes of patients in or with lumbar disc herniation. Surgery for lumbar disc herniation within 1 month of the onset of symptoms leads to a faster improvement in neurological deficit and more significant relief from radicular pain compared with the duration of the symptoms for more than 1 month. So what do we do about it? Why is that important? Again, it's all about picking the right person for the right treatment at the right time for the right condition. If you've seen other studies and heard us talk before, lumbar disc herniations, a majority of them actually can be managed conservatively without surgery. Really, it comes down to the level of pain, the level of disability, the patient's lifestyle, as well as neurological deficit. So if there is a patient in front of us with a confirmed disc herniation on lumbar MRI, what we have to do is we have to weigh what is the patient's occupation, lifestyle, and tolerance to pain. And I'm not saying like, oh yeah, doc, I have a high pain tolerance. I can deal with it. It's like, that's not the pain tolerance I'm talking about. This is going to suck no matter who you are. Do you have the um, resources available to handle it over the time frame of conservative care? That's more what I'm talking about from a pain tolerance. It's a pain lifestyle. Um, Then there's the matter of deficit. Neurological deficit is the big thing that we're going to watch out for. So if you have mild, like up to mild neurological deficit, like it's manageable, where it's not going to interrupt your life, it's not scary, it's not in the scary places, and your biggest symptoms are mainly pain, then we have that conversation of, hey, do you have the resources where you can manage this over a roughly, I think the average time frame was about 9 months, but it's really 6 to 12, depending on the size of the herniation. Can you go through this for more or less 6 to 12 months where it will get better, but it is going to take time, where we will have to build strategies around it, but you will be able to avoid the knife because your case is confirmed to be conservative, like it can be conservatively managed. I've had it where patients have told me, yep, I can, and we've worked with them. I've had it where, nope, I can't because I'm a line chef. It's my occupation. I'm the sole breadwinner. Even though I know there's going to be the potential for post-operative complications, as well as recovering from surgery, depending upon the method that they use for the microdiscectomy, and there still should be physical therapy involved. If I can get the pain, radicular pain, let me emphasize that, radicular pain, so pain going down limbs away from the source of the actual issue. So if that's the main problem that you need taken away fast because it's going to impede your life too much, it's going to put you at risk for financial collapse, etc., then yes, we can have that discussion that you should probably consider the discectomy, and the sooner you get it in, the better it'll actually be. So if we have a confirmed disc patient, what should really happen based on this study and the others that we have is an open conversation between the patient, between the potential operating surgeon, between everybody involved as to what is going to be the best route for this patient, because everything has to be taken into account. Lifestyle, budget, finances, pain lifestyle, tolerance and compliance, as well as, from the get-go, is this a conservative case or is this a surgical case? Because there are some cases where you will actually have some of these discs disrupting your cord so much that it is actually dangerous. So I don't want to just say blanket statement, all disc herniations don't need surgery, period, bar none. That's not it at all. You can get into scenarios where it is a huge uh, 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 risk to a person's life in some scenarios, or like you can have risks of, one thing I'm thinking of is you can have risks of sustained neurological compromise leading to somebody being disabled if things aren't taken care of in extreme cases. So these are all on a continuum of mild, moderate, severe. And what should happen is an open, honest conversation between somebody who's comfortable from a conservative standpoint handling these disc herniations, all the way up to a surgeon about what is this person actually going through, what is the level of herniation, is it mild, moderate, severe, is it having significant neurological compromise, etc. After all those factors are weighed out, and we're able to at least present the patient what is the best option forward. Hey, based on your condition, the level of the disc involvement, you're either a surgical case or conservative case. However, we should also talk about what is happening right now. So long story short, what I'm rambling to say is the most informed consent possible. You need to have informed consent. I need to lay out what is going to actually happen if you go the surgical route. I need to lay out what is going to happen if you take the conservative route. We need to have an honest conversation between these three providers, the surgeon, myself, or a provider like myself, and the patient in front of us, about all routes present to the patient in front of them. And what we need to do is make sure that we reach a decision promptly, because if it's conservative, then we need to set up expectations, set a prognosis, come up with timetables, and figure out what's going to keep them the most active at a given point in time. But if they're surgical, then based on this study, getting them in sooner is going to be better, which I see with a lot of other conditions. So you can basically take the last 10 minutes of my rambling and sum it up as you need to have an informed consent about what is going to happen in your case, what you're more likely to benefit from, conservative or surgery, but then have informed consent, honest conversations between the providers, conservative and surgical, as well as you, to figure out what is your absolute best route going forward, understanding everything in front of you. Last three studies. Risk factors for the development of knee osteoarthritis across the lifespan, a systematic review and meta-analysis. What did they find? 131 studies evaluating 150 plus risk factors. Things that they found: previous knee injury, older age, and high bone mineral density were associated with an increased risk of incident radiographic knee osteoarthritis. So that's where I mentioned this wasn't listing if patients had symptoms. This was just based on radiographic evidence who had a higher risk of developing knee osteoarthritis, not who is at risk of feeling knee osteoarthritis. So that's what they found. So if you had previous knee injury, older age, and high bone mineral density, they could basically stack the deck in their favor and say, if I was a betting man, if they have these factors, they're more at risk for developing knee osteoarthritis. Two risk factors that they also saw was being overweight or obese, and that previous knee injury accounted for 14% of all incidents of that radiographic knee osteoarthritis. So very significant when you have over 150 risk factors, and two of them took almost 15% of all of the incident findings for this. So that's huge. Other modifiable risk factors that they noted included an occupational physical activity, also seem to contribute to radiographic or symptomatic knee osteoarthritis. So there's where we actually have people starting to feel it. Interesting. Now, moving on. Last two. These are, well, the last one I can tell you is very, very quick. This one, I'm trying to figure out how much I want to talk about it. The vertebral artery during passive cervical range of motion and spinal manipulative therapy, a systematic review and meta-analysis. Paradoxically, they found that just having somebody rotate your head for you, as well as extend your neck for you, actually applied more strain on your artery than spinal manipulative therapy. This is something that came across some studies a few years ago. One thing to note is they did these studies mainly on cadavers, so cadaveric specimens, which again, you don't have live tissue, you don't have active muscle guarding, you don't have a lot of the things that would actually play into confirming these theories, but it's at least a great way to start because you have the same anatomy. It's just entirely passive because it's dead. So you don't have blood supply, you don't have some of the muscle pliability because there's no blood and no activity in the muscles. So there is a difference. I want to state that out right now. There is a difference, but it gives us a cool concept to discuss. They looked at 9 studies, met their search criteria for providing data for a meta-analysis. Adjustments consistently produced lower vertebral artery strain compared to passive range of motion in the upper neck segment. The meta-analysis revealed greater strain during range of motion compared to adjustment, particularly during rotation. Again, I don't want to get into a long discussion of what people see on social media, what is sensationalized, what is good or bad over neck manipulation. Talking with other providers, looking at social media, some people are almost phobic about neck manipulations because of what they hear and what people say about it. Like, you adjust a neck, you're going to cause a stroke. But on the other hand, you have just monotherapy clinics slinging it all day, just doing adjustment after adjustment after adjustment, but not really screening patients for who is actually going to benefit from it. Like anything else, it's just going to take an informed consent about what is going to happen, the potential benefits and the potential risks. So for studies like this is going to add layers of confidence for us being able to say adjustments are not causative of any sort of incident like that, vertebral artery dissection, cervical artery dissection, because we're finding that the way that we're taught to adjust is not causing any excess strain on those structures. So it's adding layers of confidence for us to be able to say that during the questionnaire. What really needs to happen, though, is just an understanding of the people that do suffer those conditions because they are scary, because they are, well, I'll just leave it at because they are scary. It really has to be understood that people need to be screened and selected appropriately in order to have these adjustments, even if they are safe, because the most common symptoms associated with somebody going through an active vertebral artery dissection is going to be neck pain and headaches. It's just like, do you know how many other conditions have those exact same symptoms? A lot. Do you know how many of those other conditions benefit from cervical manipulative therapy? A lot. So I think it's best summed up in a tale of two patients. So for me, there was a patient 3 years ago now where he had insidious onset neck pain. That was pretty much his limiting issue. He had a little bit of range of motion deficit on one side. And he was saying, yep, all I need is a good adjustment. I know I've gotten it in the past and I'm going to get better. Well, we go through our exam, tell him his blood pressure is, I think at the time it was 136 over 88. And he's just like, huh, that's high for me. And it kind of put me on pause. It's just like, high for you. That's good to know. That actually is going to tell me that until I address that issue, I'm less likely to adjust your neck. I'm not saying it completely rules it out, but because you have acute high blood pressure for you, it's definitely a factor that ticks the box against adjusting. And I would have to tick several for adjusting and weigh those out back and forth about what's best for the patient, which again, go back to my previous rant about you need to have a lot of different tools in the toolbox to match the patient in front of you. So I am not constrained to, oh shoot, I can't adjust, therefore I can't do anything. Quite the opposite. But I digress. So for him, it was like, well, let's start you off on a lighter therapy because you also have a family history of some other vascular disorders that I don't like. It puts you at a higher risk profile that I'm not about to bet into. So I treated him over 4 visits while he was also talking with his primary to get in and have his blood pressure read 2 or 3 other times and go through an EKG series. And long story short, he was eventually put on a blood pressure pill, hypotensive, oh, sorry, a hypertensive medication to get him back to a reasonable blood pressure. And even though I was taking care of his symptoms, they always came back. Well, once he got on the blood pressure pill, all of his headache and neck pain symptoms went away. So his issue was not mechanical. It was his body was dealing with increased blood pressure for his system that it did not like, and it came off as neck pain and eventually headaches. That is what you would see with a potential vascular aneurysm in progress. So you need to have somebody that is willing to screen and go through additional safety profiles and considerations prior to manipulation. You know, there are others like people are hesitant if they have some vertigos, but if you have like a cervicogenic vertigo, neck manipulation is actually one of the top tier. Do I want to say top tier? It is one of the most effective first-line interventions for resolving a cervicogenic vertigo. So again, tale of two patients. The first one, it was a blood pressure issue. He's not going to get better with neck manipulation, even though that's what he said has worked for him in the past all the time. You always need to be checking these things and evaluating these things, selecting the right, treatment for the right patient at the right time. Versus the last cervicogenic vertigo case that I had, it was a discussion of, I know this is going to be paradoxical, like I'm going to adjust you, which is twisting your neck very, very fast, which is causing your symptoms right now. But we have a ton of great clinical outcomes with doing manipulation and resolving the cervicogenic vertigo, which again, we have to screen that the patient is going through cervicogenic vertigo and that it is nothing else. Okay, so right patient for the right condition at the right time. This is adding layers of confidence that we are not causing vertebral artery dissections. We still have to have a proper informed consent though, and make sure that we're selecting the right treatment for the right patient at the right time. So this is not carte blanche where I need to sling fire and adjust everybody's neck 24/7 because there's zero chance of something happening. This is just, oh, it's not likely to be causative, so I can feel confident going into that, but it does not strip my responsibility away from telling you what, or going through in a proper informed consent, what I'm going to do, why I'm going to do it, and you have full rights to ask any and all questions and refuse treatment accordingly, or pick another one that I need to tell you about. So that's that. Last one. I told you this one was short. Weight-bearing MRI of the cervical spine, a scoping review of clinical utility and emerging applications. MRIs are funny in the sense that they were all the rage a few years ago. They were diagnosing everything under the sun, whether or not it was actually relevant, because even if you found something, was it clinically relevant to that patient? And the interesting thing is they were well, they still are such a gold standard tool that sometimes if you get an MRI that says you're either clean and healthy or it doesn't quite know what's there, you're just written off. Well, most of the time, the gold standard old way of doing an MRI was you'd lay on your back, face up, you'd go through the claustrophobic machine and get the image. You were not dealing with gravity at the time like you normally would when patients oftentimes have symptoms. Ergo, you weren't standing upright or you weren't weight bearing. Technology has advanced to the point where you can actually get a ton of different approaches to your MRI. There's actually some cases with certain disc herniations that they don't really stand out, or not just disc herniations. There's other conditions, including disc herniations, that are more prevalent and easier to be seen if you're, for example, face down. There, there are other conditions that are better suited and better served if you're weight bearing or standing up. So what I want to say is, yes, MRIs are a fantastic tool for the right patient with the right condition at the right time. And it may also be that we have to have a consideration of what is the best MRI for you. Is it going to be, Old Faithful, on your back, looking up in the claustrophobic machine? Is it face down? Because based on your symptoms, we have a better shot of seeing what we need to see with you face down. Or now, is it weight bearing? Because your tissues change whether they're unloaded or they're loaded. So if we just take a look at the results and conclusions, then I'll be able to end this video. 9 studies published over this time period, 2008 to 2025, met the criteria. Upright and dynamic MRI detect posture-dependent, look at that, posture-dependent changes, including spinal canal narrowing, cord compression, foraminal stenosis, ligamentous buckling, cerebellar tonsillar descent, altered alignment, cerebrospinal fluid flow differences, etc. Findings were more pronounced in flexion, extension, and upright postures compared with supine imaging. Normative studies established reference metrics for that motion and prevertebral soft tissue width, yada, yada, yada. It also highlights applications in connective tissue disorders, Chiari malformation, and upper cervical chiropractic practice, although most studies were feasibility reports with small sample sizes and heterogeneous protocols. So their conclusion: emerging evidence suggests that weight-bearing MRI provides added diagnostic value in selected cervical spine and CCJ conditions by revealing dynamic or load-sensitive pathology not captured on standard supine imaging. While current evidence is preliminary, protocols and large multi-center outcome-based studies are essential to validate diagnostic thresholds, improve reproducibility, and define the role of weight-bearing MRI in routine clinical care. So this is really just to say that if we're going to have an MRI, I'm typically going to be talking with the radiologist to figure out what is going to be the best approach for you based on our clinical suspicion of what's going on. So really, it's just setting up expectations like, hey, you're going to go in here, they may put you face down. Okay, if we have to have, modifications, like you don't do well in a tight space, there's, wide bore MRIs where you have more space, you're less likely to be claustrophobic because you're going to be put in these weird positions. Hey, I know you're going to be feeling uncomfortable when they take this weight bearing MRI because that's where your symptoms are. But hey, if that's where your symptoms are and we get a picture of it, we're that much more likely to see what's going on. So again, in the rare occurrence that we do think we need an MRI, well, actually, I shouldn't say the rare occurrence. In the occurrence where our clinical prediction and our clinical thought process requires an MRI, we will be having an honest discussion with the radiologist, the radiotech, and you about what is going to be the best position to get the picture in to give us the best look on what is going on so that we can set up and have the best chance of awesome results. But I've talked enough. This is a long video. I apologize. Thank you for sticking with me this long, and until next week, take care.